Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Welcome back to the Sit and Stay podcast brought to you by RipsyTech. As always, I am one of your hosts, RipsyTech Product Manager Parker Anderson, and I am joined by RipsyTech Founder and CEO, the festive Tom Tarshis.
I was wondering if you were going to stick with the no adjective, but I felt the pause coming, and good timing for the season. Thanks, Parker.
Yeah, well, I'm actually realizing maybe not so good timing because we were just talking about when this episode would likely get released, which probably won't be till January. So, speaking to you from the past, hello.
Very good.
So, for this week's episode, we're continuing the discussion around evidence-based medicine, and last week we focused a lot on talking about evidence-based therapy practices, and the week before that was kind of like our primer to the topic of evidence-based medicine. And this week we wanted to specifically focus things on prescribing practices that are evidence-based. So you're the psychiatrist between the two of us. So before we get into it, what anything to say?
Yeah, I mean, this is really a very, very important topic in psychiatry. I think it's an important topic in all of medicine. But if you think about, in general, some of the highest iatrogenic, big word alert. What does iatrogenic mean, Parker?
I got nothing. I don't even know. I got no root words there. Genic, I got that.
So when there's a bad outcome, if you say it's an iatrogenic outcome, it's like people did what was intended and had the bad outcome. And the highest source of that is through prescribing, really, in medicine. If you think about, and it is something even more concerning, I think, in psychiatry, but it's true in all other areas of medicine that sometimes, usually when you're going to see your primary care doctor, unless you're getting a couple stitches in or a knee brace, they're pulling out, well, they used to pull out the prescription pad, but now what's your pharmacy? And so that's just the way the medical world is built. And so when someone comes in and you've got 10 minutes till your next patient, you're just, okay, what can I prescribe to not get far behind? And, that's what patients are expecting. And that's this problem that has developed over time in these fields. And I think it's especially relevant in psychiatry, or I can say from my own experience, it is not uncommon to see kids and adults sometimes come in being on 5 or 6 or more medications. And you're sort of like, what are we doing here? And, I think ultimately the responsibility comes down to the people who write those prescriptions, but there is this other segments and aspects of our healthcare system that facilitate some of that practice.
That's, extremely well said. I've definitely had, I've had an experience of, you see a provider for 15 minutes just to talk about a prescription, and, you can't help but feel like maybe there was something missing. It's hard to feel like the decision around what medication I should be taking can be made based on a 5 to 10 minute chat every few months.
Yeah. And I think, well, I mean, and even if it can be made reasonably, if having rapport and trust and a relationship with your patients,
right,
makes that possible when things are going smoothly and at a later time. And unfortunately, a lot of systems are not set up to allow the building of that relationship and appropriate discussion. So, yeah, and
Yeah.
as a case in point, Parker, there's not a single piece of research to support more than 2 medicines in psychiatry, yet often people are on 3, 4, 5 medicines. So right there, we're violating evidence-based practices. If you have someone coming in on these multiple medications, and even if a medication, um, is reasonable for one symptom, when you start mixing all these medications, you're changing the nature of whatever evidence does exist about, prescribing one medicine for anxiety. Well, there's no study if you're prescribing that, but they're already on these 2 other medicines, and that's where things get murky.
Well, so yeah, you've brought up a really good, I would say, consideration for, prescribing in psychiatry, and maybe let's talk about what are some other good key considerations, or just you know the nature of prescribing and what the best practices in the evidence says.
Yeah, good question. And I think, especially I work with kids, and anyone prescribing medicines for kids, it does, that brings an extra layer of, not necessarily complication, but there's fewer medicines with the full evidence base, good studies to support their use. And you have to watch for, parents are consenting for medications for their children, not the children themselves. So trying to still be able to age appropriately, talk to your child patient about taking a medicine, making sure they understand, again, age appropriately, why they're taking it. Once someone is 13, 12 or 13, it should really be more their decision, even though we need parent consent. And being very careful and answering all questions people have about medicine is a key point. I think the other sort of relevant data fact around medicine practices, and here's the quiz for you, Parker. What percent of people, anyone who has a prescription, actually take their prescription as directed?
100%. Come on, easy. I got this.
It is 50%.
Okay,
So you give
that was
out,
going to be my actual guess.
you give out a medicine and it says take this pill at 8 p.m. every night. Only half of people are actually going to do that. So whether it's forgetting the medicine, taking it the wrong time of day, and we can sort of track some of these things through when people request prescription refills and other items, but we're already starting with a very bad success percent. So for a lot of, say, psychiatric medicines that you really need to take daily, not, asterisk, it's probably okay to miss up to 2 days a week of certain medicines, but you've got to really work with a bond and with the patient and do some psychoeducation on strategies for being compliant with the medication. So sort of explaining it and getting the buy-in and being logical is one piece, but then you have to figure out the patient education piece for them to be compliant. So it's another piece of, evidence-based prescribing.
So when it comes to prescribing, and you're looking at actually, let me take a step back here. How are you as a prescriber evaluating which medications are appropriate? Are there kind of like commonly recognized medications where, if for particular symptoms you say like, yep, that's my go-to? Like, how do you develop that as a prescriber? Because I know that the pharmaceutical companies are always trying to come up with, new drugs. You go to any conference, like for psychiatry, and there will be pharmaceutical companies there trying to kind of gain awareness for their new drug that's treating XYZ thing. So, how do you as a prescriber develop that? How do you kind of weigh the risks and benefits of the available evidence for any given medication?
Yeah, and before I answer that, Parker, why are there always these new drugs coming out to treat the same conditions from pharmaceutical companies? What drives that?
Capitalism. Well, money.
Well, money, of course, money drives everything. But what specifically happens in the world of medications that is highly correlated with when new products come out? And I'm maybe might be too much of guess what I'm thinking, but there are patents. If a drug company develops a new medication and then the patent expires, then the medicine is allowed to be made by generic manufacturers. And something that was once $100 a pill might be $1 a pill, it's just good. It's exciting for patients when that happens. It was very exciting when Prozac went generic, which was the first sort of the new generation of antidepressants with much fewer side effects. And had just started some of my training when Prozac went generic. So the only option we had to get it for our poor patients or patients without the means to or have insurance was to try to get samples from the drug company or get patients enrolled in the drug company's sort of free medicine program. So and the best example that we joke about with this is there's two SSRIs. A lot of people have heard of them. One is citalopram or Celexa. And then this medicine came out. Came out later than Prozac and Zoloft and Paxil. And they were like, so we're the best. Look, we have the cleanest biochemical profile. You're going to have less headaches and stomach upset. And then as soon as that medicine's patent expired, they came out with citalopram, citalopram, known as Lexapro, which is a good medication. But then the drug company people came out and said, oh, this is the best medicine. It has the fewest side effects, best biochemical marker. And those of us who had been around for Celexa's release were kind of like, you kind of said the exact same thing about your other medicine. Who was lying when? And it's just this kind of, what's the sales pitch around? Well, we modified the chemical formulation slightly to get a new product we could patent, and now we're going to push that, even though it has the same exact efficacy as all these other medicines. So anyway,
as a provider, is there any upside to choosing Lexapro versus Celexa in that situation?
Yeah, well, and let's just look at the SSRIs to kind of look at to answer your question. So we have, there's really 6 SSRIs if we think about it, all of them with pretty reasonable evidence for treating anxiety and depressive disorders. One of those medicines has really fallen out of favor because of some side effect and organ issues, and that's Paxil or paroxetine. So that one is kind of not prescribed too often. And then there's another medicine called Luvox or fluvoxamine, which was sort of the first SSRI to be known to be successful for OCD or obsessive compulsive disorder. That one used to require twice a day dosing. They came out with a controlled release formulation, but because of that, it also maybe doesn't have the same market share. But if someone's coming in, they've heard about SSRIs, they have moderate depression, and they say, what should I take, doctor? What happens then is well, here's the list of 4 medications that all kind of have from the same class. They all have similar side effects. They all have similar evidence base and indications for successfully treating what you have. And then it's an issue of, I'll usually give the names to the patients or families and say, hey, why don't you go Google them and see if anyone stands out to you. I'll also usually ask, hey, almost everyone's heard of Prozac or Zoloft. Do you have any good or bad feelings about that? It's kind of ubiquitous in United States culture. And sometimes people will say, oh yeah, I never wanted to be on Prozac. Or someone will say, oh, there was that movie where someone took Zoloft and it worked really well. But this is that sort of art of prescribing where, okay, there's usually multiple medications that could be a reasonable starting point. How do you help engage the patient in the process and make a decision about what to choose? And that's where our role should really be, explore their feelings about it, and explain things well and let them take ownership in making the choice. And so that's, um, I think that's worked well as a strategy with my patients over the years.
Okay, so it sounds like there are kind of it does sound like there are like some well researched, kind of like highly regarded, like these are kind of the clear choices without having to really shake things up to, pick something new. I'm wondering if they're, I guess, like for you, if you were to be picking a new medication, like how do you, or I guess, have you been in that situation of having to look at a new medication that's maybe come to market and maybe there's been conflicting evidence, or maybe it's not even something that you consider, but I guess, have you ever kind of like, come across anything that's like, hey, the evidence is saying this, but also it's saying that, and maybe that's not what we want, in regards to effectiveness or safety of a medicine. Anything to say there?
Yeah, well, Parker, I think, the FDA requirements on what you have to go through to get a medication approved on some level handles a lot of the evidence-based discussion for prescribers. So that sort of gold standard I discussed in our therapy episode about two good studies by different groups showing solid data like that is sort of being reviewed in depth by the Food and Drug Administration plus safety profile. Now, but to your point, like there's a new Alzheimer's drug that was approved that has some potentially pretty severe side effects. It did, and this has been controversial on whether or not it should be improved because although it looked like there were some markers that showed things being better, it was not any type of robust finding, and there is significant toxicity with the medicine.
Mm.
However, Alzheimer's is devastating. There's no good treatments at all, and there's a lot of people interested in just having something to try, and that's what. And a bunch has been written about this. That's what helped push through this FDA approval for this new Alzheimer medication. And then there are lots of other experimental treatments, and if you think about cancer treatments, chemotherapies, if someone's very near end of life, you can, and there's, drug development takes years and years and years from phase 1 trials to being on the market. So if there is something that can be helpful, you can often petition to get that medication prescribed depending on your current health status as a kind of off-label approved use. So I think the Alzheimer's one getting FDA approval is a little bit different, because once you have that FDA rubber stamp, people kind of assume this is a good medicine to treat something, and that's not always the case. I think with medicines, and especially in psychiatry, this has been the case. There's what we call off-label medicine use. And do you know what that is?
My best guess would be, I feel like I should know this. My best guess is just taking something that you're not prescribed.
Oh, no, but that's
That's its own
common
thing.
also. Yeah,
Yeah.
off-label is where, okay, Depakote is an anti-seizure medicine, but someone noticed, hey, it seemed to help this patient who had seizures and also bipolar disorder. It seemed to keep the bipolar disorder in check. So before that could be studied in depth, people would hear about it and start prescribing Depakote for bipolar disorder. And that would, Depakote is approved for bipolar disorder now, but before that approval came, prescribing a medicine for something it wasn't intended for is called off-label use.
Okay.
And that happens very often in all aspects of medicine. I mean, that's how, right, Rogaine, and there's all these interesting stories about, unintended side effects that turned out to be cool treatment pieces. And one, right, Rogaine is a blood pressure medicine, and then people are like, hey, it grows hair. So it made a lot more money pivoting on that drug. And that's this like, when you're explaining how we think medicines work to patients, it's often we don't really know, but we think it's X, Y, or Z. And there's some, significant horror, I shouldn't say horror stories, but, when I was in training, because specifically anti-seizure medicines, a lot of them have shown benefit for treating bipolar disorder. But that not all of them. That led to Neurontin, this or gabapentin is the generic name. A lot of people started prescribing this medicine for their patients. The thing that prescribers liked about the medicine is it has much fewer side effects than other medicines for bipolar, than Depakote, than lithium. And so people were prescribing this medicine. And then they're like, oh, my patients feel a lot better. Well, it's because they're not having the side effects they used to have. But there is zero research supporting this medicine as a successful treatment for any type of mood disorder or anxiety. And however, and the drug company knew this, and they were fined and paid huge fines for the sales reps marketing it off for this sort of off-label use to treat psychiatric illness. This happened initially a long time ago, then like a decade passed, and then I started noticing it being my patients coming in again, being on the medicine for, a mood disorder or bipolar 2. And it's always frustrating and concerning that these patients are trusting the prescribers, but there's even a lot of prescribers who think that it actually has valid evidence, and that's where paying attention to the real science and evidence behind medicine, and then it's our obligation to be aware of that and not get people on medications that don't really treat what they're coming in for, and this is prevalent in psychiatry.
Wow. Okay. I guess on that note, are there ever any like patient specific factors that as a prescriber that you're considering when you're choosing a medication?
Yeah, that's a great question, and that's very true. So, for example, we know some medicines are more likely to cause weight gain and some are more likely to suppress your appetite. So knowing, are you working with someone with a history of an eating disorder, you're going to maybe stay away from something that's going to suppress appetite. Are you working with a teen who's a little overweight, or that you're not going to want to choose a medicine that is going to cause weight gain? And is there a first degree relative that had a really good response to medicine? We know that can help with also being a good response in yourself if you have a good data from a family member that's also had success with the medicine. Right, there are patients with liver disease or kidney disease or heart issues. For example, if you have someone with congenital heart issues that you might not want to choose a stimulant medicine for ADHD, and you'll want to go with something that is safer for their heart. And so there are those set of patient characteristics that can be very important in your prescribing choice. It seems like there's an asterisk on everything or somewhere to like watch out for. There is this. Parker, you could get a blood draw and send it off to this genetic testing lab, and they will send you back information saying, oh, you should take Prozac instead of Zoloft. You're a 92% match for Prozac and only 78% for Zoloft. And it is, So there's all these companies that will do genetic or neuroimaging. This is not just related to prescribing, but
Yeah. I
the,
mean, is this in this case a good, useful thing, or is it a
it
bad, giving people the wrong type of information sort of thing?
yeah, and it's not really based in science or whether I don't even know how these companies get their statistics, but there's no um, and this is the reason why none of these things are covered by insurance because there's really
Mm,
no data to suggest that however these companies are doing their genetic analysis of your medication susceptibilities or medication metabolism or what's going to work best based on other aspects of your DNA makeup. It doesn't bear fruit, and so, sometimes people come in and here's my $5,000 I spent showing that Zoloft is the good medicine for my depression, and I'm kind of like, well, we could have just figured out you had depression, and here's the four medicines, and Zoloft's one of them, and it often takes several months to figure some things out, but ultimately you figure it out, and I feel bad people spent a lot of money to tell them something that is sort of an obvious starting point for most,
mm.
many conditions.
Yeah, I think that's a good segue into our final question, which has to do with, I mean, Zoloft might have strong evidence behind it, but what do you do as a provider when the patient is requesting a medication that might not have a good evidence base?
Yeah, and this is a good. I'm very strict, and I would work very hard on the psychoeducation, and I would not prescribe it because it would hurt my soul. But a good example, something that comes up often is people asking about supplements or
Oh,
natural medicines, and I that should be a good. We can add that to sort of our evidence-based series about there are a lot of um, naturalistic treatments that have reasonable evidence to help. And I think for something like over-the-counter products or vitamins or probiotics or things people read about in support groups, I definitely asked to take a look at them, and I'm mainly making sure there's nothing very harmful there in the ingredient mix. So I think if it's an over-the-counter product or an alternative medicine treatment, as long as it's not harmful, I'll say, there's not really science to back this up, but if it's not causing any harm or concern, like, hey, lots of people respond differently to lots of things, so it's okay. But if someone comes in specific, like if someone came in, like I will never prescribe Neurontin for, gabapentin for a psychiatric issue,
mm,
unless I'm tapering someone off of it. But that's an example of if someone came in and really wanted a medicine that had no research or science behind it, and in fact had those negative articles that you mentioned at the beginning, I will not prescribe it. But along with that would be a very candid discussion of why I'm not going to prescribe it, and try to direct people to um, better options.
well, and I'm assuming this happens a lot. What do you do when somebody comes in asking for a specific medication? Maybe I don't know, maybe a young adult comes to you saying, "Hey, I want Adderall." What do you do there?
Yeah, I think, initially it's sort of a redirect around, hey, well, welcome to make an appointment for an assessment. We're going to get to know each other, do some questionnaires, and then, have a discussion about what we think is going on and what might be helpful. I'm, Adderall is a first line treatment for ADHD. It is a class 2 controlled substance, so there's issues with that. Um, there are there are places that kind of their business model is to maybe I'm trying to watch what I say a little bit, but maybe to like give out some medications without the sort of same thoroughness, or getting to know people as well. But I think I wouldn't necessarily say, and then there are lots of people who would just never see that patient. And that's not necessarily appropriate either. So I think it's kind of redirecting around, well, let's do an assessment. Let's see what's going on. We always talk about biopsychosocial different treatment for options. And, then it's this issue of, if someone comes in and takes the time, we get to know each other. There's no red flags around prior issues or anything, knowing that the medicine is being sold or is being abused, then there's no problem with prescribing that medicine. If there are concerns around one or more of those items, as a specific example, I recently had an adult come in who had a history of ADHD as a kid and was really struggling with getting anyone to prescribe stimulant medication because it's just adult ADHD with going to different, I think he had been to 3 or 4 psychiatrists, and the minute he sort of mentioned that he had been on stimulants, it was like, well, I'm not going to prescribe that. Well, I'm not going to prescribe that. And I think that's a little bit of a knee-jerk reaction to, most people coming in needing a stimulant are not there for nefarious reasons. They're like struggling with their job or life or relationships, and to have this blanket no response. So I remember when we did our couple session intake, got to know him a little bit, hear about the story, and then he was actually like surprised when I was like, well, let's talk about, stimulants, and almost couldn't believe that someone was actually listening to him and gonna prescribe. And it has not been a problem. It's very easy now to kind of monitor use of medications and make sure nothing bad is happening. Maybe those other people he went to had a bad experience with someone misusing medications and it was traumatic for them, so now they just don't even bother getting involved. So there's lots of reasons for that. But that was a very long-winded answer to that. If someone comes in like really asking for something specific, it's always a redirect around like, let's get to know each other and see what's going on, and take it from there.
All right, this is all really good stuff. This is super interesting. I could keep talking about this, but we should wrap things up. Do you have a mental health business moment this week?
Yeah, I will sort of borrow something. I was going to borrow something that happened to one of my colleagues
Okay.
and it's sort of, it's almost a general like business moment, but my colleague had been reached out to about, partnering with another, partnering for this kind of new business venture and be interested in participating, anything like that. And they had said, yeah, I'm interested. Like, and then they had one phone call about it, but then the people never followed up, sort of radio silence, not even saying like, oh, we've decided to go another direction or anything else. And then, but they didn't remove my partner from their mailing list. And then the holiday newsletter came out showing the person that they ultimately hired for this, position. And it was just kind of, my colleague, it's not a big deal that they chose someone else, but where's the respect to sort of say, hey, here's an update, or, not responding to a couple follow up, like what's happening with this. And then you just sort of see in the newsletter, oh, wait, I thought I was maybe going to be doing that. And given my own history with various business relationships, it is also I am sometimes still mystified about some of the just lack of basic respect around certain items that happens. But yeah.
Yeah. I think, yeah, even for people who, interview for jobs, that can be a common experience. I mean, that in that case, it is kind of like a interviewing for this position. But yeah, even just for people seeking a new job and to not hear back, you can always really appreciate and respect the people who will get back to you and then provide you with like feedback for, maybe like the reason why they maybe didn't take you, or just anything that they can offer you that will give you the leg up in the next interview that you have. That's always pleasant to see.
Yeah, and I think if the reason this was a little more egregious is it's not like my partner went out looking for something like this. It's a colleague from years past reaching out like, hey, da, da, da. And so you're going to initiate these conversations and take someone's time and then just ghost them is like, man, not cool, man.
Yeah, not cool at all. All right, well, let's wrap things up here. This is a good episode. We will pick things up. Well, the audience won't notice, but we will pick things up in a couple of weeks. All right, there you have it. So this was another great episode, Sit and Stay podcast, brought to you by RipsyTech. If you have questions you want to submit to an audience Q&A, we should really do that soon. Or you're interested in featuring as a guest on the show, send us an email, sitandstay@ripsytech.com. All right, Tom, this is great.
Thanks, Parker. Happy holidays. Bye.
Happy holidays.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.